Good evening, everybody. This is Anna Vick. I'm here with Push for Empowered Pregnancy, bringing you a very exciting conversation. We hope that you will come in and chat with us, send some questions in if you have any. And we're going to go ahead and go around and introduce ourselves again like we did last time. I'll go last. So let's go with our special guest tonight, Dr. Florescue.
Hi, I'm Dr. Heather Florescue. I live in Rochester, New York, and I work at a great private practice. And I'm here to kind of talk to you guys about my interesting journey through most of my career, but also especially the last 2.5 years, and kind of talk about where I think we can do so much better in our country to reduce stillbirth rates.
Awesome. And Samantha, our executive director.
Hi, everyone. Thank you so much, Heather, for being here with us tonight. My name is Samantha Banerjee. I'm the executive director of Push for Empowered Pregnancy. I am here because I'm a lost mom. My daughter Alana was born still 2 days before her due date in 2013 after a totally normal and healthy pregnancy. We had no idea that stillbirth still happened in this day and age until it happened to us. And in the 8+ years since my daughter's death, almost nothing has changed. So we are here. We are here as Push to change that. We want to see everyone. We want to see everyone being educated about stillbirth. We don't think any parent should have to walk into a stillbirth never knowing that this could even have happened to them. We want parents to never have the regrets that we have about not paying attention to our baby's movements and other simple things that we could have done to at least have the confidence that our baby's death wasn't avoidable. There's 65 babies dying every day in the US and being born still, and more than half of them could be saved using today's technology with very low cost, no risk changes. So that's what we're here for.
And Allie.
Hi, I'm Allie Felker. I am a legislative co-lead here at Push for Empowered Pregnancy. My son Henry was stillborn on July 1st, 2020. And very similarly, I had never really heard about stillbirth or really known that that was something that could happen to a perfectly healthy baby in a perfectly normal pregnancy. And so I was completely blindsided, and just through my journey of healing and connecting with people, I was able to find Push, and I'm here so that less babies will be stillborn, less families will be just completely devastated, and we are here to end preventable stillbirth.
Allie, I'm sorry for your loss, and Samantha, of course. My son also was stillborn in 2015. We had a perfectly normal pregnancy. I feel like we're all saying the same thing, but unfortunately, I think that's a big point to make because a lot of us didn't have any clue that stillbirth was something that could happen, especially, doing all the right things. This was my second pregnancy, so I treated it the same way. And my doctors never told me much about stillbirth. I don't even think it ever was mentioned, to be honest. And, nothing that you read in pregnancy really tells you warning signs or anything like that. I was, prepared to kind of count kicks just because I heard of it, pay attention to movements, but I didn't know why. I didn't really know what was that to me, I guess, because I figured my baby was going to be healthy. He was normal the whole way through. And we did have a crash C-section in the end because I noticed a change, and I went into the ER and they delivered. And that's when they didn't resuscitate my son, so he was stillborn. But I am definitely, as part of my charity work with Push for Empowered Pregnancy, really dedicated to making sure everyone is aware about what stillbirth is, the fact that it is happening in this country. 23,000 babies a year, no progress, no change. And I think that's a big point of the discussion tonight. So I'm very excited to hear what Dr. Florescue will mention. I know I've seen her speak about it, so I think you guys will find this very informative, especially knowing that stillbirth can be prevented in many cases, and we're just not doing enough in a lot of practices. And it's just not, there's no protocol, right? There's nothing that's consistent. So we can go into some questions. If anyone has any, please feel free to throw those in the chat as well. We'll keep an eye on as much as possible, but why don't we start with really softball question for you, Dr. Florescue. When you
Sounds good.
started out, how did you feel about how you were preventing stillbirth? Like, was that even part of what you were really trying to do? Or were we just doing, your standard care, whatever it is that you were trained as? And was that a thought?
I don't think it was a thought at all. I think there's this myth out there that the prenatal care net is so great that anything it doesn't catch was just it was meant to be, and the phrase that I know everybody they've heard is these things just happen, and it's a very common thing. So I don't think I had any awareness that stillbirth, like your lady's stories, could actually be prevented until I went to the Star Legacy conference in 2019. So it was not part of my education. I mean, clearly all of prenatal care for high risk pregnancies is to avoid complications for mom and for the baby, right? So clearly there's a thought about stillbirth prevention, but it's for the hypertensive, diabetic, twins, my case triplets pregnancies where, there's increased surveillance, increased watching. But I think the idea is that anybody who is like you three ladies, that there is nothing prenatal care could have done better, and it was just going to happen.
Yeah. And I will say that resonates, because that's exactly what my doctor told me. He said, we don't know, sometimes healthy babies just die. And there was no effort to really even help me understand the cause. So I was just in a tailspin trying to figure it out, like what happens. We were all blindsided, my husband as well. And, it was just one of the most shocking experience of my life, because like you said, if I even thought about a baby dying at term or close to it, it was like a genetic problem, something really bad with the health of the mother, something unavoidable, of course, like a cord, possibly, like that's what you hear about, right? Commonly. And birth, situations that kind of went awry. But for me, like, it seems like a given, like not now, because I know better, but at the time of those pregnancies, like feeling like, oh yeah, I'm doing all my prenatal stuff. Everything's good. Every visit, the quick checks that they do, they're like, everything looks great today. So yeah, I find that to be the case with a lot of the losses that I've heard of. Also, not very many had those high risk things, like I didn't have any of those in my pregnancy. I don't know about the rest of you ladies.
No, yeah, totally low risk. Same thing. Heather, can you tell us when you were in medical school, right? You're trained as an obstetrician. What do they say about stillbirth? Is there a chapter in your textbook? Is there a lesson about it? Like, what are you told about stillbirth? Never even mind prevention, just stillbirth in general.
Yeah. I mean, medical school, you don't cover it really. So in residency, medical school is really it's not going to get into that as much. I mean, they may briefly cover it on the OB/GYN rotation, but really you're going to dive into that stuff in residency. I feel like residency well equips you kind of for, what are the zebras almost? Like, I think almost anybody can say, oh, let's make sure she doesn't have syphilis, even though I've never seen a patient with syphilis really in my entire career. So there's that kind of knowledge. There's kind of, I think, a basic knowledge of the labs you would order. What's funny is when I was a resident, I used to say to patients' families, if they ever said to me, well, what do I say to somebody who's had this happen? Like, people would just mention it to me, and I'd be like, we get really good training about what to say when somebody's had a loss, but that's because we got good training. And you just, and kind of try to give them advice that I kind of know what to say and family might not. And I have no idea where I came up with that, because nobody told me what to say. I kind of figured it out all by myself. So it's kind of comical that I actually came up with this. So there was no formal education on like the emotional care. And there was certainly nothing about prevention aspects, other than, of course, as I said, as a triplet mom, I had a gazillion ultrasounds and NSTs and all that kind of stuff. So there was always an attempt to catch people like me who were extremely high risk for stillbirth, but not for the kind of normal risk patients. The other thing that was very profound in my residency was, I remember my first term stillbirth. And I remember profoundly that this woman came in for a labor check and then was found to have that her baby was stillborn, and no real mention when she came in about concerns about the baby. And when we delivered the baby, it had been clearly deceased for several days. And I remember thinking that, when she was a relatively young mom, that she must have just been in denial. But I mean, I think it's very clear, beyond clear to me now, that she was just not educated. And really, I only have had one term stillbirth patient who appeared on labor and delivery for decreased fetal movement, who I could tell truly knew that her baby had died. The vast majority of them came in for something completely unrelated, or came in for the decrease in no fetal movement, but didn't even know what that meant. So.
Yeah, exactly. I mean, and I just want to point out there that you said the mom clearly wasn't educated, right?
News, everybody.
Yeah, Heather, I think you're a little frozen, but hopefully you'll come back in a second. We can hear you though. So the mom wasn't educated, but that doesn't mean that the mom didn't learn everything she was supposed to, right? I mean, I don't think you could say about me, Allie, or Anna that we were not educated in our pregnancies, right? I took a 10-week birthing course. I read every book, blog, and website about pregnancy I could get my hands on. Like, I thought that I knew everything there was to know about pregnancy. So even that I think is the core of the problems here, is that even when you have a mom who is actively seeking the information to keep her baby safe, it's still not getting to them. And I just wanted to make sure that was clear, that that education piece is not ever the fault of a mother. It's not because a mom didn't try or didn't do all the things she was told to do. And I think that's the crux of the problem, is that we're following all the rules, we're following all the orders, and we've been promised that if we get past the first trimester, that our baby's going to be fine. I remember very distinctly, especially at 37 weeks, thinking, okay, now if anything happens, they'll just cut me open and that baby will be fine. Like I breathed this huge sigh. I was very anxious through my pregnancy for no reason, as far as I could tell. Oh, Heather's coming back. Yay. And when I got to 37 weeks, I breathed a sigh of relief, because I thought there was no way anything bad could ever happen. No worries. You're right. It's 2020, 2020. Wait, what year is it?
Oh, 2022.
Oh my God.
Oh, you're on two phones.
Oh, Heather, we've got W.
I know. I was trying to do. I don't know what happened. Now I have to get out of this thing. Let me leave that.
Well, the good thing is Samantha has a lot to say, so
I always worry.
So I don't know where you lost. I don't know where you lost me, but basically, I was saying that in my entire, I think, career up until 2 years ago, I only had one term stillbirth that I saw that actually truly I remember, and she's still my patient to this day, her walking into labor and delivery after calling with no fetal movement, where it was clear from her body language that she knew that her baby was stillborn before we diagnosed it. Every single other patient, it is either been a labor check or a rule out rupture, or I have a headache. And then when they find that, it's like, when did you last feel the baby move? And they're not even sure, because it was on the radar. So. Yep,
exactly. And that's exactly the problem.
Can I throw a question at you from our chat here?
Yes, of course.
One of the mothers mentioned that she had a full-term stillbirth in her second pregnancy as well. We're sorry for your loss. No cause determined. And she said she didn't have any clue either about stillbirth as a risk. And OBs usually give you a pamphlet when you first come in for your appointments with basic information on how to have a healthy pregnancy. We're told not to eat the deli meat, don't change the cat's box, all those things that you mentioned in your talk. And she said no mention of monitoring fetal movements at all. Is there a standard for what should be included in that type of pamphlet, or do you just do whatever?
Yeah. I mean, I don't think we don't really give too many, like, we try not to get too much materials. People, the more you give, the less they read. So there is no, and as I talked about, as you kind of alluded to, as much as it's terrible that we have 24 to 30 listeria losses a year in our country, there's not a single woman who I've had to explain to her what foods to avoid. I've never had that happen. And, so this is well ingrained. And as I kind of say, acog has many guidelines, even for things like listeria or toxoplasmosis, which I've never seen in my entire career. But there is nothing that addresses fetal movement education.
I was like terrified of that stuff. And like, I didn't have sushi once, and it was one of those things.
Yeah. And I mean, I even, as I show, like even Zika virus, it's like,
Yeah, I wanted to say Zika because you mentioned that
yeah,
also. And I was
yeah.
like, I remember during that period, I had some family members were pregnant, and that was the thing. We were terrified of Zika, even
Yes.
though I guess the rate was nowhere near what
Oh,
stillbirth is,
yeah,
right?
nowhere near. And that's one of the things as we kind of go into our rage part of this is that they didn't have prospective studies about Zika. They didn't have this data, but within 5 seconds, ACOG had a whole page saying, here's what to do if your patient has Zika, and here's our recommendation. So this idea that they don't think there's enough information to be able to give something out in terms of just stillbirth awareness for patients and fetal movement education is really just such a shame,
Have
and
you thought about that at all? The Zika, like why did it, because it got sensationalized, like
I
with
think
the
it got
media right away, like
sensationalized.
Mm.
it
And
was
I
so
think,
intense. I remember it. I was really afraid,
Mhm.
to be honest. And I was like,
Oh,
oh
we
my
were
gosh, I mean, it
afraid
was a
too.
terrible outcome if that would
Yeah.
happen,
Yeah, we were afraid too, definitely. And I think part of it was, which I know I've talked to Sam about, is why ACOG doesn't do what we want them to do is I think that right now, and I'll say it bluntly, people have stillbirths and they say, well, these things just happen and there's no litigeny, which I know Jill has kind of talked about. And I'm not saying that that is obviously what I want from this, but I think ACOG thinks if we say we can prevent this, then we have a mother like you who says, you never told me that stillbirth could happen. You never educated me about this. And this maybe could have been prevented if you told me. And that's not where I want this to head. I want it to be something where we give the best care and we don't have fear of what the repercussions will be. And I really do think that's what's kind of holding it back. And when it comes to things like Zika, I don't think any patient was really going to be able to, because, we tell them to wear the bug spray and, that was it. So I think there was a less concern about their constituents.
I feel like anything that you can say that's more mother cause, they're on it. Like,
yes.
don't smoke, don't drink,
Mhm.
don't you dare lay on the wrong side. There's so
Yeah.
much for us and on us. And when it comes to these things that are more protocol, which I want you to discuss what you're doing with your practice, it's like they don't even want to infringe. They don't want to tell people how to do their job. And they don't, I don't know if it's an insurance matter too of how much things can be covered, but it just seems so like very suspicious, like anything mother related, like it could be the mother's fault, then we know about that, but
Yep. Any
But
opportunity.
I think there are
to
many
fix it
things that
anymore.
they do tell us.
Oh no, Heather, you're kidding me.
Yeah.
she needs a stronger
Hope I didn't
Wi-Fi.
lose
We'll
again.
send you Wi-Fi
Yeah.
for next Christmas.
Are you
I'm just
there?
kidding.
Yeah.
So I have a really good question on here for her. I hope she comes back quick enough, but
Yeah.
I won't ask it until she gets back
Yeah, wait
in.
until she comes back.
I think
What did
there's
you think,
also-
Allie, as far as like your education on it? So you mentioned like it wasn't really.
Yeah, I mean, so I was 28 when I was pregnant. And so my mentality the entire time was, you're young, you're healthy. I feel like I remember my doctor saying like, everything's normal, you're young, you're healthy.
Yeah.
And then at some point, I don't even know where I saw the word kick counts. And so I
I'm
said,
back.
yay.
I think ACOG's doing this. They're like
Yeah,
purposely.
they're like,
We
Bottle
did
her into
announce
it.
it a lot.
Bottle
I
it.
was a little worried this would happen. No, just kidding.
yeah.
So Allie
Um,
was just mentioning that because she was young and healthy, that
mhm,
she
that there
felt
was
like she was
nothing.
doing everything.
And I do remember asking my doctor, do I need to do kick counts? And this was before my 3rd trimester. And she said, no, you don't have to worry about that yet. And then at my 3rd trimester appointment, she said, oh, you can do kick counts now, but never explained what that meant, how to do them, what monitoring fetal movement even looked like. And so I eventually ended up going to the ER with decreased fetal movement. And I don't even know where I knew those words. Like, I don't remember anyone ever telling me decreased fetal movement. I think I said, hey, my baby's not, I haven't felt my baby. And they're like, okay, decreased fetal movement and come on in. And unfortunately, I was sent home. And when I came back the next day, he was gone, which is a whole nother story. But the other impression I got was that my doctor never wanted to scare me. And it was like, you're fragile. Like, I never felt like I was empowered. It was more of like, I want to protect you from any kind of fear of anything bad happening. And I don't know if you have felt that as well, or if there's even that kind of mentality in an OB practice.
Oh, no, there's 100% that. And I think we even saw that in the town hall, which of course Sam got my rage from that too, was that the doctor that they brought to represent this said, well, maybe we shouldn't talk about this so much because women might be scared. And like, this was somebody who is coming to talk about it, and this still happened.
So this is a great question from the chat.
Do you guys hear me?
Can you hear
Yeah.
me?
Yeah.
How do you think we can get stillbirths into
Yeah.
residency curriculum or get hospitals to be open to having some ground rounds focusing on the care of families experiencing loss or pregnancy after loss? So yeah, basically wondering how do we start
I don't know.
pushing for this stuff?
I don't know that you need to reach the residents as much. So if ACOG comes out with guidelines saying this is what fetal movement education should be and kind of bases on what I've been doing for the last 2.5 years, it's going to follow that it's going to trickle down to resident education. So anything that they do that comes out scientifically showing improved outcomes is going to trickle its way down to residency education. So you can sturdily start, and I certainly have made some changes in that, I think, in how the residents approach it, but I don't know that you need to get to the institutional level. I think it was a really great step that our boards used the stillbirth kind of guideline. They did put that on our maintenance of certification list, which really is a good thing that they put that on there. I think it's a sign that there's somebody out there who thinks that people should be refreshing on stillbirth. But again, that, ACOG bulletin on stillbirth that was updated really didn't address anything about fetal movement education, prevention, things that we can do better. It was really kind of more of the same.
Hey, Heather, one other question for you. When you were being trained as an OB, what were you told about bereavement after a stillbirth? Like, what was your understanding of what it's like?
Nothing really. I mean, yeah, I don't. So did I learn great bereavement skills? Yes, from nurses. I did not. Yeah, I don't. So I think I naturally always kind of knew what to do. The physician who made me want to be an OBGYN, he was phenomenal with bereavement. And so I think I learned from him. My first term stillbirth, I was funny. It was a very Heather thing. I was like, well, of course you go to the funeral. I mean, that's what you do, right? And so I show up at the funeral and I'm the only one there, and I'm expecting to see, her doctor and her other doctor. And I was like, well, that's weird. Wouldn't you just go to the funeral? I mean, that seems like you're supposed to do. So I attributed more to my training than I ever should have. It was just a natural instinct. It was a natural instinct. And it was, of course, wonderful nurses who I think model much better the behavior of how we should be in these situations.
Yeah, and that's what I've heard from other doctors too. We actually have a couple OBs on our team who were trained as obstetricians and then went on to have stillbirths or neonatal losses themselves. And what I hear from them is that their entire view of what losing a baby is changed after it happened to them. That they were under the impression that the day that you give birth to your stillborn baby is the worst day. And as long as you can get them through that nightmare of a day, everything is going to be uphill from there for the patients. Like, you send them out the door and it's just going to get better and better. And it wasn't until they got home from losing their own child unexpectedly that they realized how absolutely backwards that is, that in many ways the birth is the best day. It's the only day you get with your child.
Mhm.
And then you're faced with the rest of your life and trying to figure out how you ever pick up the pieces. Right. And they said that, I think, and I personally think that that's a huge part of the problem as well. Like the way the incentives for our medical system are set up right now are backwards. We have, like you said, there's no accountability when a stillbirth happens. There's no mechanism for accountability because, first of all, stillbirth is rare enough, at, less than 1% of births, that 99 times out of 100, if they just roll the dice, that baby's going to be fine.
Yes.
So, right. So why do you take a risk of doing something at 1%, especially when if you take the risk to intervene, say, and deliver a baby early, say you see something wrong with the cord, you see a small placenta, you see weird test results on their BPP, and you're just like, I don't know, maybe I should take this baby out. It's like 30, 35 and a half, 36 weeks, and you take the baby out, and they end up in a long NICU stay. That doctor, even though they intervene to save a child's life, can get sued for millions of dollars from the insurance companies, even if the baby lives and is safe. Meanwhile, if they just roll the dice and they say, well, I'm just gonna wait and see what happens, and they roll that dice, 99 times out of 100, the baby will be fine. If the one time out of 100 the baby dies, guess how much they can get sued for by the parents? In most states, it's about $200,000, because that baby does not count as having lived and died. That baby does not count as a human being. And the only thing that you can sue for is the mother's emotional damage, which I can tell you is worth a hell of a lot more than $200,000. But that's what it's capped at in most states in this country. So why would any doctor in their right mind take that risk, right? I mean, that's number one. Okay, but let's put all that aside. Let's say, doctors go into medicine because they want to help people, they want to save lives, right? That is what doctors do. This is who you are. So of course, they're not thinking about getting sued. They're thinking about, how do I save this baby's life? And the thing is that I don't think the average OB understands just how bad of an outcome this is.
Oh, definitely not.
Right? Like, I think that first of all, no one wants to go there emotionally and thinking, well, if I just done something a little bit differently, this baby might be alive, right? We know as mothers, because we've had that thought 8 million times, how painful that is. So we completely, again, understand why no doctor wants to go there. But I think the other part is they have convinced themselves, or the training or something has convinced them that it's not as bad as it sounds, that, oh, they're young and healthy, they'll have another one. They don't understand that this is a devastating event, that this destroys not just the parents, an entire family. This destroys an entire community of people. Like this is hugely impactful. I mean, and it has lasting benefits. Like having another baby does not fix it. It does not fix it. And I think that there is so little understanding of that, of just how bad of an outcome this really is. Actually, after my daughter stillbirth, my OB even said to me, well, this was the second worst outcome, because she thought it would have been a worse outcome if my daughter had lived and had like developmental disabilities. I was just like, I disagree. I very heartily disagree with that. Like this is the worst outcome. Your baby dying is the worst outcome. And the fact that anyone in their mind can try to excuse that is just absolutely baffling to me. And I think that's a huge part of the problem too, because even if you ignore the financial incentives, and you only look at the moral incentives, if you don't realize how bad of an outcome that is, again, why take the risk of doing something differently, right? So I think that's a big problem too.
I think it's a big part of it as well. And I don't think that anyone I know truly believes it's not a huge impact. I just don't think they know how long lasting it is, because I know that because I call them constantly, and I have such a close relationship with my patients after, but I don't think I would have had the insight into it, and I don't think I would understand. I remember there was an analogy somewhere at the conference about like kind of the waves of grief and how you never kind of get out to the shore. And I really feel like I think about that almost every day. That's, these women, even my women who are 5 years out or so, 10 years out, their feet are still a little bit in the water. And, and it's one of those things just to, always be mindful of. But I agree with you. I think there's just, I don't know how, I don't know how to get so much of a change of a mindset, and I'm open to any ideas. I think we need to change the mindset of prevention, and we need to change the mindset. And you're totally right. The vast majority of the time the things would have been fine otherwise, but what can we do in our practice for, you know, making sure our patients do know about fetal movement. And I'll also say that I think the fetal movement education that we give also translates really well to trusting their instincts about everything. So I'm very careful when I give the education that this isn't just call me right away if you're worried about your baby and trust your instinct. It's call me if you're bleeding, call me if you're in pain, call me if you have a headache. So there's ways to incorporate, and I do think it not only does it improve the fact that my patients call and don't, you know, but one of the things I showed them, and I don't know how many people have seen the card, is it goes from trust your instincts directly to call your provider. And I tell patients between the trust the instincts and call the provider, tragedy happens. And there are many, many women who go to pregnant, you know, people who go to the, you know, online and they say, oh, this is normal. And they don't ever make that phone call. Or a spouse or the grandmother is a big, you know, offender, you know, says, oh, this is normal. And they listen to their mother and they don't call. So that's what we really are trying to do, is get our patients to trust their instincts because they're the experts on their baby, and call. So it's making sure that delay doesn't happen. And then the other piece that's so important that we incorporate is just a standardized response. So nobody in my practice, when they answer the phone call, the vast majority of the time it's nurses, is going to say, oh, this is normal. Don't worry about it. Do some juice or crackers. Call me back. So my nurses have such a standardized response that it is very, very rare that a patient, and they'll come to me, you know, a 23-weeker who's not moving, and say, you know, what should we really be doing in this situation? But, you know, they really kind of roll with this protocol. And, you know, just to step back for 1 second, is there is excellent evidence that checklists save lives. The operating room system is very much based on air traffic control, and we do checklists, and they seem silly sometimes. You know, do we know what surgery we're doing? Do they have, like, are they attached to the table? Is this happening? This happened? But we do that every time, because when you do those checklists, lives get saved and medical errors get eliminated. So why there is absolutely no attempt for a checklist on something that 40% of women will complain about in their third trimester, and 15% will complain of multiple times. So nearly half of pregnant women are going to have this concern in the third trimester, and there's absolutely nothing to guide with. And to me, that is when we talk about what to be going to, is really that it doesn't make any logical sense. And it needs to, can we change the psyche of people? I don't know. You know, and believe me, I have those nightmares when I have the woman coming in with decreased fetal movement. Is that tracing going to look so bad that I'm going to deliver a neurologically, you know, very hurt baby? And how do I explain that to that mother at that moment? And I think if I face that in my career, I just have to be honest and truthful and say, I can't tell you the neurological status of this baby. And it is your decision, you know, it always is your decision. But I hope that I never end up there, because that to me is terrifying. You know, and
I
which is
think
why I
you
want
kind
my
of
moms.
mentioned it a few times. I just want you to clarify. Stillbirth is often preventable. We say a lot. What have you changed in your practice? What are you doing?
Yeah, tell us about the
differently?
protocols. What did you change when you found out stillbirth was preventable?
Why, you know, we know why, but we want everyone else watching to know why you started to do this, and how have you seen the rates go down, and what?
Can I actually ask a question? Oh, sorry. Can I ask a question before we get into that? Because we've talked so much about, like, the paradigm shift. What changed your mind, and, like, what brought you to the Star Legacy Foundation? Like, I'm just so curious.
Yeah, so I've always been very devoted to bereavement care and grief counseling and stuff. So our local chapter asked me to go. So, and when I went, I really didn't know why I went. I knew I wanted to go, but I didn't know why I went. And I thought I was going to meet many other doctors there who had the same passion as I did. And I remember seeing this room full of people, and I went and checked the CME the first day to see how many people were actually claiming CME. And there was like 10 total people. And I was like, there's like 10 MDs here. And then like 5 of them are pathologists. I was like, wait, so I'm one of like 5 doctors, and another one's actually from my town. And it really was like, wow, where nobody's coming to the table with us. And then Dr. Calderwood spoke. And I just remember being in shock. And I didn't move for the entire time she spoke. And I
rewatched it like a day ago. I love that one.
Oh,
if anyone hasn't seen it, she's
Yeah, for anyone who
Yeah.
hasn't seen
Scotland.
it, Heather's talking about, it's Dr. Catherine Calderwood. She was the chief medical officer of Scotland, and they were the first to do the care bundle, basically the stillbirth prevention protocols. Parents came to her and said, we need to do something about stillbirth prevention. She had she tells a story about this horrific weekend that she spent, I think, as a resident, long weekend where she was 9 months pregnant herself and then had 3 patients with stillbirths in a 36-hour period. And she was so disturbed by it and that it stuck with her throughout her career. So when she got into this position as basically the head of all doctors in the entire country of Scotland, and parents came to her and said, we should do something. She said, yes, we'll do it. And she went to the other OBs and said, okay, we're going to set a target and we're going to lower stillbirth. And she said, everyone came back at me and said, this cannot be done. You're setting us up to fail. The stillbirth rate is what it is. It's been like this for decades because there's nothing you can do about it. And she said, well, I crossed my arms and I said, we're going to start somewhere and we're going to try. And she said in her adorable accent, and she's so awesome. And she did it. She said, she basically randomly selected a target of 15% in 3 years, and they beat it. They hit 23% reduction of stillbirth.
I love that speech. She's
And
so
yeah, I was there with you, Heather. We didn't know each other at the time, I don't think, but we were watching. I was watching live, and I just
She
the
says,
energy in that room.
I had to admit to my colleagues that I was wrong because
I had to admit to my
overshot
colleagues I
it.
was wrong. Yes.
Yes, you can. And it's an arbitrary number, of course, but like the protocol, like you're saying, having that in place that can save lives. And it's been done in other countries.
Well, and let's pause for, so when I found out about this, I got on the plane and I started furiously taking notes. Like, what am I going to do with this when I get home? And I contacted a high-risk OB doctor who I thought, hey, maybe he'll be interested. And I really started to get just the door was closed in my face, basically, by, anybody who I tried to get to come on board with this. And so I started my little grassroots effort in August of 19. So shortly thereafter, I established the protocol in our practice. And I have done a lot of grassroots things, especially before COVID, and definitely some very receptive people to it. But the idea that the amount of people who said to me, well, this isn't by acog, this isn't American, this isn't in the United States, and therefore it's crap. And I wanted to be like, this chief medical officer Scotland, and it just wasn't getting the recognition. And I still can't fathom that when a whole country does something that we can't be interested in, to apply it here. So are you guys having me?
You were breaking up a little bit, but we heard you again. Your
okay.
Your face freezes, but we hear
okay.
you. Yeah, no, it's
okay.
It's infuriating, and that's the thing that's so frustrating about stillbirth is that it's like you were saying about the Zika thing. It's not like there's no research. There's decades and decades of research, but a lot of it was done internationally.
It's not in the United States.
Just not United States, and so everyone here just turns their head like Australia and England and Norway, they don't count. They're nothing.
No, yeah.
So ridiculous.
And they'll acknowledge, ACOG put in the article saying that up to 45% of term stillbirth could be prevented. They did that. They printed it. And they acknowledged the, Lancet series that we have the second to lowest, reducing rate compared to all high resource nations. But yet, in Australia, they don't know what they're doing over there. And I don't understand. Yeah. And so I incorporated the whole protocol in our practice. I always say that really the big changes are the ones I already mentioned to you guys. So at 20 to 24 weeks, we educate about stillbirth. We educate about fetal movement. Really just frank education. I always start saying that only 45% we think can be prevented, because I really don't want the mother to ever think that, it is her fault if tragedy happened. So I'm very blunt about that at the beginning. And then I just hand them my card and I show them all the steps of it. I dispel the myths right away too. And I really just have a nice frank conversation with them. And then we address it every time. So the language we use with our patients isn't, is your baby moving? It's, do you have fetal movement concerns? And, and then we make sure when they call, we have a whole standardized protocol. So those are really the big parts. There's parts about not smoking. Our smoking rate is so low for our practice that it's really not something we have to address too often. And then it's making sure to not miss growth restricted babies. And that's, and that we really don't miss a ton either. I think the acog keeps on handing out more and more people who need ultrasound. So we really have it all incorporated. And I don't think that's so much of something. So the catch-all is really the education piece, the encouraging the direct phone call as soon as they're concerned, and then making sure they're not getting mixed messages. I know everybody likes to ask me about like results. We are not powered high enough to say that I prevented stillbirth. Do I have stories of women where I think these protocols made a difference? Of course. But, Harvey Kleiman agrees with me that unfortunately you're going to have somebody who always says, well, that might have ended up okay regardless. So I think it'll be many, many years with a practice of my size before I can truly say that I prevented stillbirth. So I'm also an incredibly superstitious person. So do I think the protocol is working in our practice? Yes, but I'm not going to tell you what has happened in the last 2.5 years because I don't want to jinx it. So
and how about what is the patient response been to this? Because again, we hear so much. Oh, we don't want to tell patients about stillbirths. It's just going to scare them. There's nothing they can do about it. And again, we, as we talked about earlier, feel really strong. Number one, that's just insulting. Like
it's patriarchal, it's insulting,
and it's not empowering. It's not empowering, right? You're empowered when you know about risks and you know what to do to lower your risk. Not telling someone about something isn't empowering. That's disempowering them. So so how do your patients respond? Were they terrified?
No, nobody's been terrified.
Nobody fainted?
Yeah, I have not, as far as I know, and I think my staff would tell me, I have not had a single patient call angry from this education. It really and truly, because it's not politicized, I mean, they get angry about other kinds of education I give these days, but there's no anger. Sorry, I had to throw that in there. But I love the COVID cards, by the way. But nobody gets mad about this because it's a truthful conversation. And I say to people very clearly, stillbirth is not contagious. And me telling you this is not going to make it more likely to happen. It's going to make it so much less. And just, the idea, uttering the word doesn't mean that's a destiny for my patients. And I think it's taking the time. And I want to briefly address another thing that's kind of holding back ACOG is the AFFIRM trial. AFFIRM was a large trial that randomized people to education or no education.
About fetal movement in particular?
Fetal movement in particular. And
what did they educate them specifically? What did they tell them about fetal movement for the ones who were?
That's where the issue probably lies. So they were powered very well. They did find a 9% reduction in stillbirth rate. So they did actually see a result, but it wasn't enough for statistical significance. And the theory in why, from experts in this, why they didn't see this is it was, again, the pamphlet. It was a handing of a pamphlet about fetal movement. It wasn't a passionate doctor or PA or midwife or nurse sitting down and saying, let's talk about this. Let's educate you. The part that I show them and I say, please don't look on the internet or call your mother or the nurse in your family who knows everything and is going to tell you not to call your doctor. And I have no doubt if the education is given consistently and passionately, it would make a difference. But you hand somebody a pamphlet the same way I got, my vaccine thing that said, this is what you call about it if you're worried about the vaccine. It's 10 pages long. That's not going to reach people. And I think that was the issue with the ARRIVE trial. And I know, not the ARRIVE, sorry, the FIRM trial. And I think that's, even if you talk to the authors, especially if you talk to Alex, he's ill about it, who's one of the main authors, he says the same thing. And, it was a well-designed trial, but it wasn't clear how the education was given.
That was Alex Easels.
Yes. Yep.
Okay, you're dropping names like everyone knows them.
I know who you're talking
about. Alex, that guy.
Oh, Alex.
He's only the best doctor running the Rainbow Clinic.
So I have a question. What is the role of ACOG and how much weight do their guidelines actually have bearing on
what doctors do?
Standard of care? Yeah.
Oh, huge. I mean, and almost everything that we do is based on those bulletins and is based on those guidelines. And I do trust them. I mean, and that's the frustrating thing is if ACOG tells me that I should prep the vagina when I do a C-section in labor, I'm going to change the next day. So I think there are many, many things that is simple 2-page thing that comes out in a monthly green journal will reduce, and I believe that since the beginning. I believe since the beginning, if just a simple 2-page thing came out and it was a bulletin and it was something that everybody who is involved in the field read, and it goes in the midwifery journal too, or wherever, I think change would happen simply from that. And I believe that since the beginning.
Yeah. And the thing that, like you said earlier, that I really love about the idea of, very explicitly educating patients about fetal movement. And I think, again, like you said, a really big part of it is building the relationship, right? Handing them a pamphlet with the information is not going to do it. But when you sit down and you talk to your patient and you treat them as a trusted partner, instead of as this, fragile flower, you're taking care of their pregnancy, and you treat them like a woman who knows what she's doing, that empowers mom, and that will make her come to you not just about fetal movement, but about any concerns that she has, right? And that's how we catch preeclampsia.
Yes.
That's how we catch cholestasis. That's how we catch anything. There's a million things that can go wrong in pregnancy, right? And that's what I love about stillbirth prevention, is that the things that you do to prevent stillbirths prevent all bad outcomes for mothers and babies, right? So many of the same root causes. And if we can get people doing them for stillbirth, and the numbers for stillbirth, unfortunately, are far, far bigger.
Can I throw one thing in, because we don't have a lot of time? Dr. Florescue, I know we don't all get the right education on it. Please just talk to everyone watching, because we do have pregnant audience as well. And what should they know about movements?
Give us your talk.
Like, let's pretend that you're their doctor and you're going to help them out here to understand it, because none of us were given the proper education.
None of us were.
I was told the same thing, like, oh, baby moving okay today? That very random. And I'm like, yeah, of course. I mean, what do you mean? Like, what is that supposed to mean? I didn't even realize why. And I like your gas tank analogy that you stole from Dr. Harvey Kleiman too. So you could throw that in if you want, but feel free to just give it to them, because I want us to educate here. We're not obviously here to scare. We're here to empower. Happen to us. It is a low percentage. So you can keep an eye on your baby and, speak up and do what you need to do. So go for it.
Oh, we want to do gas tank?
Do your thing.
Give us the whole talk.
Teach everyone about movements real quick, because I think that is key. We can't change a lot of what is being done and care. Everyone's going to get different levels and whatever, but we can all learn how to speak up for ourselves.
This is one thing that is within your control, right? Is being able to pay attention to your baby's movements and report to your doctor.
I mean, and it is in your control, but as I said, it's also incredibly important for women to know that if they do everything right and they come in, something has happened to their baby, it's still not their fault, but we can,
you can be even more sure in that case that it's really not your fault.
Because exactly. You did everything you could. Yeah.
Oh no, Heather.
It's such a glitchy night.
One of my patients who, you there? Okay. So one of my patients who had a healthy baby from this outcome was noticing significantly decreased fetal movement at 35 weeks. And she said she heard Heather would want me to call, and she had the card on her refrigerator, and she called instantly. My partner brought her in instantly, and she had a tracing that looked like baby needed to be born, and it's a totally healthy baby. And that's what we want. We want women to not hear in their ears, and I say this to patients every single visit too, is you're never bothering us. So we really want to phrase you're not bothering us. We want you to call us. And so it's not just about fetal movement. It's by saying to people, please don't not pick up the phone, because you're worried about your headache, or you're worried about itching on your palms and your soles, or something just doesn't seem right. I think pregnant women should always be empowered to reach out when they are worried about anything. And again, this patient, it was fetal movement, but she said, I heard your voice in my head. And that's kind of where I think the AFFIRM trial maybe went wrong, is because it wasn't giving enough of a passionate kind of direct education. People need to hear it from the providers, or the nurse, or anybody in the practice has to say it to them. It's not just handing them a pamphlet.
And how early do you start saying this? So let's say this is your patient and she's been seeing you. Do you say it from the moment they're pregnant? So you start talking about, so when is that?
Yeah, 20 to 24 weeks is based on like the Norwegian study. So in Norway, they kind of did a study looking at that kind of age for education, and it showed that it drastically shortened the time before they call. So I introduced it then. I think introducing it too early, the mother doesn't even know, a first-time mom, what fetal movement is. So I think it's something you want to kind of hit right as the women are starting to notice their baby's movements, because that will, I think, make a big difference.
And what if somebody has, a friend or a family member who's pregnant and they want to educate them if they feel like their doctor isn't? Like, what are some of the things that we as community members can do to help in this conversation?
I mean, I think certainly women should feel empowered to bring this up to their doctors and say, fetal movement education and, kind of promote it. I think this is stuff to post about. I think this is stuff to educate about and say to pregnant family members, hey, it's a myth that they slow down at the end. It is a myth that they don't move in labor, and really just trying to educate people. Unfortunately, no matter where you go, I mean, if you go onto any of these websites for pregnancy, they have it all wrong. So it's really just saying to people, please just, call. Now, of course, the issue is, if you call a lot of practices, you're still going to get the misinformation. So it all trickles right back down to, we need to change the narrative. And the best way to change the narrative is for ACOG to tell everybody to change the narrative. Because
Do you think like the CDC or anything like that, like a bigger, anyone should be mentioning this?
I don't think they would be. I don't think anybody really, I mean, even when it comes to things like COVID, ACOG kind of guides me. So I think it really is as I said, it's the holy grail is to get ACOG to tell people, because again, somebody might call right away to their doctor, and then the person who answers the phone says, oh, that's totally normal, your baby's not moving, they're getting squished, and then it's done, right? So you have to have the response on the other end of the phone to take that concern seriously.
Yeah.
I like that in your speech that you were talking about the flow chart kind of thing. Like, this is what we do for everyone. This is the first thing. Come on in.
Yep.
Was it ultrasound for everyone, or
it ends up being almost everyone, but it's from the UK Saving Babies Lives protocol, and it basically brings everybody in. If they have a risk factor for stillbirth, they get a pretty much immediate ultrasound regardless of the NST, because I don't get me started on what I think NSTs do in terms of false.
Don't get us started either.
Yeah. But then, we do that, and then we do the ultrasound. And then the most important piece is my nurses, who do a lot of the flow sheet, they ask the patient, are you reassured by what we did today? And I think that is such an important thing, because if you spend any time in this community, and of course I'm speaking to this community, there are numerous women who have numerous NSTs and they're never reassured by them. And I had a patient the other day who, had a perfect NST, and she's like, but I don't care. I'm telling you something's wrong with my baby. And the listening to that, but I had everybody in my ear saying, why are you giving this patient? This looks great. And I'm like, are you listening to her? And trying to educate people that the patient should come before what's on a screen.
That's a big one. Yeah. So just a fetal movement myth thing. What's the myth you heard? We know about one, like 10 kicks in 2 hours. I think you mentioned that in your article. So there's
I don't use that at all.
Normal. Yeah, but that's something that's still very much out there, and even I think explained by some doctors. So
definitely. I don't use that at all. I tell women, if they have a job like mine and they want to get to know their babies, they should download Count the Kicks and use that to get to know their babies. But that is never what they turn to in the time that they're worried about their baby, because their babies can move 100 times per hour. I'm not reassured by 10 kicks if it moves 100 times per hour. And so it's really one of those things I do very much at the beginning, educate that kick counts are, it's your fourth kid. You're paying absolutely no attention to this fetus and you need to check in with it. That's what the power of a kick count is.
Yeah.
What about
know your normal, right? Know your normal. You got to know what's normal for your baby.
Yeah. What about drinking orange juice or cold water? That was what I was told.
Oh no, she's frozen again.
Wow,
she's gone.
While you were on the ultrasound machine.
You killed her. You killed her with the orange juice.
I know. I just blew her away with the orange juice question.
She said, not that again. Well, just so everyone knows, that's not correct.
It's not correct. Don't do the orange juice.
Orange juice.
Hype out.
I'm just not a doctor, so I wanted a doctor to say it.
To say it, yes. But Heather will agree with us. if you found your
We're putting words in her
toddler
mouth now.
laying lethargic on the floor of the living room, would you pour orange juice down his throat, or would you bring him to an emergency room to get checked?
But that is so bizarre when you put it that way, but that is exactly what they
That's
do
exactly
in
what
the
they're saying.
hospital.
Like, even your child's not moving, just give them some sugar. Like,
No, and then they
spoonful
move
of
and then they
sugar
send you home.
does not fix everything.
Oh, great. Now we're just gonna have to
Wow.
rant by ourselves. So thank you guys
Oh
so
my
much for
goodness.
all the great questions in the chat. We were trying to answer some as we were going, but please let us know if we didn't. You can always DM us and we'll see if Rachel can, or Heather, I'm sorry, where'd Rachel come from? I'm reading. Heather can respond to you guys. Oh, she's back. Maybe I can fit in one more. We have 4 minutes left. Allie, ask your question. Allie has a great question. She's our legislative lead, so she is curious if there's a legal angle, I guess. Go ahead.
Does the state and federal government have any kind of bearing on standard of care or holding doctors accountable?
I have absolutely no idea. So
This is why she left. She said, "These questions, no orange juice questions."
So
I'm
one of the
done
things
with
that you
the
guys need
questions.
so one of the things I say every time I talk in a setting is I never thought this would be me. I never planned on being in public health.
Same. Never thought.
Yeah.
No, never
Either.
planned to be a public health. So I really, and that's the shame, right? Is I went to a conference 2.5 years ago. I took the reins on this, and now I'm known in the circle in a way that I would never be in almost any other area of obstetrics. The fact that I ascended to be able to be in this forum with you guys today is really speaking to how undertreated this is. The fact that you guys asked me how legislation would work and if you could make ACOG work with the government, I don't even know, because I am a private practice physician who has loved taking care of one patient at a time my entire career. And this has been the most wonderful thing to be involved in this cause, but this was not what I thought I was walking into in June of 2019. So, and that speaks to how much this cause is ignored. Is, nobody would have me come talk to you about preeclampsia. Nobody would have me come talk to you about rupture of membranes. So the fact that I am asked to talk about these things and that people are asking me to help is really showing how much we are not doing what we need to do.
I have a really great question in the chat I want to throw at you before we run out of time, but she says she had an NSC that was perfect, and this is common on a Friday, and then the baby, unfortunately, her baby passed on a Monday. So should she have demanded more than the ultrasound, or what would you have done? I guess she would have had to say she still wasn't reassured. And so
I think
what would
she
be
would,
the next step?
So, a patient like that would have the NST. Most likely I would be doing an ultrasound to check for fluid. If she's saying she's reassured at that point, there's really not much, they're kind of all the pieces that we can possibly do at that point. But then again, it's telling her that that is one point in time. And that if the next night or the next day he has that concern again, she's picking up the phone and calling.
So that's important. Everyone who doesn't know that, NSTs are just for like how many hours? Like I've been told within a couple hours, that's really all it's showing you about your baby. So if you feel it again, go back in again, basically.
I mean, I was told by a doctor that if you have a reactive NST, your baby passes, that you're good for 3 days. That's what the text.
That's what I heard.
And that is absolutely not true. Actually, the guy who invented the NST
will tell you that's not true.
Will tell you that that's not true, and that and Harvey knows him personally, or Dr. Kleiman from Yale, and he says it's the worst thing I ever did was inventing this thing, because everyone started using it in a way it was never meant to be used, and it was never intended to be predictive, and there is no evidence. Speaking of the level of evidence we need to change things in medicine, there is no evidence that shows that NSTs reduce stillbirths. And yet, what is the go-to tool that every doctor is using?
Yes.
So this is why we call BS on so many of the excuses we get for why we haven't made changes.
Yeah. As I said, I had to fight the fight for a patient who is saying, I understand you're telling me this is okay. My baby's not okay. And getting somebody to understand that she trumps that stupid screen. And it's just in, you know, and I had a resident with me, which I was like, are you, and I pointed out right in front of the patient, I said, are you hearing what she's saying? And, you know, they give this, yeah. I'm like, no, are you really hearing it? Because she's telling you she doesn't care what you're showing her on the screen. She's telling you something's wrong with her baby. And of course we kept her. And again, you cannot tell the difference of what the outcome would have been, but we kept her, and lo and behold, her baby didn't tolerate labor and she had a section for healthy baby. And a small placenta, by the way. Talk for another time. So yeah, third percentile. So, you know, all the things that say that, you know, just listen to the mother, you know, and, you know, it's just that, I think that's just where we're so lacking, is everybody just is so quick to go on to the next task. And so much of what makes you a great doctor or nurse or midwife or doula is just mindfulness. And it's just being mindful of what your patient's saying. So
yeah. And for anybody listening, my daughter passed her NST with flying colors. The doctor came in, textbook, she's a little athlete in there. She was dead 6 hours later. So don't trust those test results. If your gut is telling you something is wrong and they're sending you home, go out to the parking lot, turn around, come back in, go to a different door, find somebody else, go to a different hospital if you have to. You can literally walk into any hospital in the United States. You don't even have to have insurance, and they cannot turn you away. All you have to say is something doesn't feel right, and they have to give you all the tests. So do what you have to do to be heard. That's why we love the CDC #HearHer campaign, because exactly what Heather is saying is the problem. People are not listening to mothers. We hear it every day at Push. We get messages to our DMs. I'm in severe pain. My baby's not acting normal. I'm so swollen that I can't even get my pants on. Like, and I'm going in and they're telling me everything's fine. They keep sending me home. And we just say, go back, go back, go back. Do what you need to do to be heard, because we have heard too many stories of mothers advocating for themselves, being dismissed, and the next time they go back, their baby is gone. I don't care if you just had an NST 4 hours ago. If you go home and your gut is telling you something is not right, you go back in.
Anytime.
Don't let anyone tell you
night.
that they know your baby or your body better than you because they're looking at something on a screen. So thank you, Heather. Thank you for everything that you're doing. Thank you for educating the next generation of doctors to do better. And thank you for blazing the trail here. I mean, we love you. We just wish everybody was like you, Heather.
I see it in the chat too. I just want to let you know that people are saying how much they love you and thank you. And, you know, in honor of all our babies, that we are here just trying to push for change and try to inform the public as far as stillbirth prevention, that it is preventable in many cases. We can definitely do better. There is protocol in other countries. We're working really hard actually trying to push ACOG right now. So please join us if you're interested.
Oh, you know, I'm there.
ACOG, measure the placenta. Check it out. You can join our letter sending campaign.
Could I say one more thing, just quickly? Thank you for everything. And of course, you know, I do this all in honor of the babies and the moms that, you know, and the dads. I've taken such, you know, I just love them all. But I do want to, this is a pay it forward today as well. Joey Rymanowski would have been 7 years old today. And his family asks every single year to pay it forward. So this worked out on a perfect day, and I didn't even
and I think I picked the day, didn't I? That's crazy.
Yeah. It worked out.
Chill bombs.
Yep,
Thank you for sharing that.
Joey, thank
baby
you.
Joey,
for
7th birthday.
inspiring our Dr. Florescue. She's our stillbirth superhero.
Yeah,
all our babies matter, and I think that's something I continuously say, because I feel like a lot of people don't even know what stillbirth is. First of all, when you're pregnant, and then when it happens to someone else, you're kind of like, oh well, unfortunately that just happened to them, and you don't realize, like, well, first of all, we lost our children, Hank, Owen, Alana, Joey. It's like so many babies that no longer are here for a whole lifetime, and we're carrying trauma, you know, grief, and it's just not going to ever be the same for us. So we do not want that for anybody else. So please join our organization, Push for Empowered Pregnancy. Go to our website if you need information about empowered pregnancy tips. We try to give you all of the research that we find, and we post it on Instagram as well. And feel free to DM all of us. We are all available to you anytime if you have questions. And thank you, Dr. Florescue. We definitely will have you back.
Anytime.
We need more than an hour. We're like,
because you're all night.
Next one's on free birth. No, I'm just kidding.
let it go.
I'm getting into like breech vaginal deliveries now. I'm like all about these things. So evidence-based birth, I was telling you, want to get on with them. I have all these plans.
Yeah, we need everyone to know about it. So thank you so much again for your time and all the passion you have. And I know you feel new at it. We're pretty new too, and we're just not going to give up until we save all these babies. So
Exactly.
Thank you.
Yeah.
Yeah, thank
We'll
you.
get it done.
Good night, everybody.
Good night.
Bye.
Thank you for joining
Bye.
us.
Yes, pushpregnancy.org. You can find out more about all the things we're doing.
Bye, ladies.
Bye.
Bye.